I'll be starting off with the various clinical applications of deep learning, focusing on glioma imaging. I have nothing to disclose. So when you Google papers using the keyword deep learning, then every paper used titles such as deep learning predicts something, deep learning based on something back in 2018 to 2021. However, not anymore in these days. This means that finally deep learning has been integrated for each of the field for everyone, which is not surprising because neural networks are already proven to surpass any other algorithms when the sufficiently large data is trained by sufficiently large model with sufficiently large epochs. Likewise, in the field of glioma imaging, deep learning has been deeply integrated in everything everywhere. They're improving the imaging itself and reliability, diagnostic and prognostic performance, and also clinical workflows. Let's start with the imaging improvement. We have three topics: fast MRI, synthetic MRI, and super resolution. The first paper is about fast MRI in glioblastoma, a multi-center retrospective study of reconstruction of undersampled MRI to reduce scan times. So they used three different large training or validation datasets using simulated undersampled case-based data from the MRI by a factor of 2 to 15. They developed the reconstruction models for each of four structural sequence and undersampling rate. They use deep CNN model or model-based deep learning architecture for inverse problems, which is published in previous journal. And they tested the models using two procedures, A for single coil and B for multi-coil. They calculated the spatial agreement, volumetric tumor response assessment, and time to progression comparing the original and undersampled ones. In testing procedure B, for the fast MRI brain cohort from NYU Langone Health, multi-coil case-based data were available, and single-coil case-based data were retrospectively simulated to validate the generalizability for reconstruction models for multi-coil case-based data using the same model. As a result, the deep CNN allowed MRI scans to be accelerated by 10 times while maintaining image quality close to the original one. There were high consistency for both contrast-enhancing tumor and non-enhancing tumor volume, respectively. So structural, as you can see, the structural similarity was also comparable across URTC and fast MRI for both single coil and multi-coil. Tumor volume assessment yielded the same results, showing the identical time to progression, which is 4.3 months in median. Method demonstrated strong generalizability across different data sets, especially with multi-coil fast MRI data, where the image quality further improved. The next one is about the synthetic MRI and improving diagnostic performance for molecular subtyping. They developed generative AI using score-based diffusion model and used ResNet 50 as a classifier to predict the IDH genotype in diffuse glioma. They demonstrated the generated images according to image phenotypes, 1, tumor size, and 2, degree of enhancement. They also analyzed the effect of image features of generated images according to phenotypes. So they revealed that GAA can optimize the classification performance when nearly 400% of the original images were synthesized and added to the original ones. Specifically, the augmentation of small-sized tumors can lead to lowering classification accuracy. So they proposed the optimum number and type of imaging phenotypes that should be added to improve the performance of a classification network. Interestingly, recent Nature paper has argued that AI returns gibberish when they're trained on generated data. In other words, the AI models collapse when they're trained on recursively generated data. When the generative AI models train on real images, they generate the frequent reads of dark images. when they continuously trained on its own generated data, then it gradually forget less common categories. So the data, remember that data augmentation with generation should be carefully approached. Next topic is about super resolution, particularly for perfusion MRI. As you know, PWI evaluates the tumor vascularity and have potential in molecular genetic diagnosis and prediction of treatment response and prognostication. However, the crude spatial and temporal resolution is insufficient to capture dynamic perfusion changes and dealing with detailing the tumor microenvironment. We proposed the simultaneous spatial temporal super resolution framework, STSR-PERF, which increases temporal resolution by 4 times and spatial resolution by 4 times. So we used neural ODE for temporal enhancement and INR for spatial enhancement, which aligns with the recent trends of physics-informed neural networks. So STSR-PERF exhibit competitive performance with other state-of-the-art models, particularly outperforming the video INR in terms of PSNR across datasets, brain DCE MRI, brain DSC MRI, and brain breast DCE MRI, and also for other various resolution factors. And this is because the integration of the physical characteristics of perfusion MRI into the model design. So this, the application of STSR-PERF model to brain DCE MRI, brain DSC MRI, and breast DCE MRI, showing the enhancement of spatial resolution by 2 times and temporal resolution by 4 times. The heat map indicates the difference. Heat map indicates the difference between the ground truth and the generated super resolution images, which is ideally black images or 0 differences. So as you can see, the model qualitatively show the best performance, even compared to video. STSR-PERF shows more blank-like images. Yes. So for temporal super resolution in brain DSC, the STSR-PERF interpolates the interval volumes like this and better than video INR, as you can see in the STSR-PERF. Parametric maps such as K-trans and RCBB maps were compared, and STSR-PERF showed the highest alignment between the ground truth and the generated PK maps in brain DCE MRI and DSC MRI as well, enhancing temporal resolution by 4 times and spatial resolution by 2 times. The right side figure illustrates the restoration limitations of tumors in brain DCE MRI and DSC MRI across different temporal downsampling levels. K-trans maps showed good super resolution, including 10 times temporal downsampling. In contrast, RCBB maps cannot be restored using the model at 8 times temporal downsampling, like K-trans maps, as you can see in the left frontal lobe tumor. Let's move on to the reliability improvement. For reliability improvement, we proposed unsupervised deep learning for model-free blood-brain barrier leakage detection with DCMRI. DCMRI, based on D-weighted signal intensity, can generate PK parameters such as K-trans and VE, which estimates vascular leakage or BBB integrity in various diseases, including glioma. However, the PK model-based approach deconvolutes the AIF, which is sensitive to noise, and in turn makes the PK parameters less reliable. In addition, different scan parameters such as temporal resolution makes them less reliable as well. So we propose a novel permeability map that does not require AIF measurement by utilizing autoencoder-based anomaly detection in supervised learning manner. The perfusion dynamics of normal voxels are trained using an autoencoder, and when the abnormal signals comes in, The residual signals, which reflects how much tumor voxels deviate from normal dynamics, is used to generate residual leakage signal maps, or RLS, for tumor signals, and residual vascular signal maps, or RVS, for vascular signals. On the right side, the green box indicates the normal voxel signals pattern, and the red box indicates the vessel. You can see the vessel picking here, and the yellow box can indicate the tumor of the, you can see the contrast leakage pattern here, and respectively. As a result, these are three representative cases. They showed higher reproducibility across various temporal resolution. On the right side, you can see the undersampling and truncation in both undersampling and truncation, which is called subsampling. So the RLS showed high correlation with K-trans, but more robust results in correlation in SNR and SSIM compared to K-trans. You can see that RLS maps do not degrade as the subsampling progresses, but K-trans does. The RLS maps outperformed K-trans in predicting of IDH mutations in gliomas. Interestingly, MR angiography-like vessel maps were generated because temporal patterns of the residual due to the vessels were captured using the shared pattern of the residual, which confirms the robustness of the perfusion model. Let's move on to the diagnostic and prognostic performance. For molecular subtyping, I'd like to share the results of RSNA 2021 Registration Economic Challenge. The goal of the challenge was to predict MGMT promoter methylation in gliomas using 4 different structural MRI sequences, namely pre- and post-contrast T1 weighted, T2 weighted, and T2 flare sequences. However, the top solutions showed AURC of 0.62, which is quite discouraging. To show that the MGMT promoter methylation is not predictable, we developed and validated all possible 420 different combinations of prediction models. The best model showed around 55% of AUC, accuracy, and precision in the test set. Recall was relatively high, though, about 80%, but showed large variance. In all experiments, 80% and 60% of the 420 developed models showed no significant difference with the chance level in test accuracy and AUC. In all experiments with different prediction models, the probability score from the prediction models are randomly distributed regardless of MGMT methylation, which indicates that model does not predict the methylation well. So in conclusion, these negative results may suggest that only conventional structural MR sequences do not provide sufficient information for epigenetics such as MGMT methylation. And advanced MR sequences such as diffusion or perfusion MRI are required for radiogenomics in the future study. So not everything is possible even with the use of deep learning. After a year or two, another paper which revealed the same results was published in Medical Image Analysis, which is a top journal in medical engineering. They also showed randomly distributed latent features for each class. In review papers published on radiology, they referenced our paper that MGMT was not predictable, which is initially rejected so many times because of the previous studies with false positive results. In prognostication, we developed deep survival prediction model using 3D structural MRI for diffuse gliomas. We utilized 5 different multicenter retrospective data with survival information and trained using 3 different USA data sets. The C index was 0.71 and 0.68 in the external test sets 1 and 2, which is Seoul National University Hospital and Severance Hospital. The Kaplan-Meier plots showed significant risk stratification using log rank test for those external test sets. The GRUD can confirm the tumor location with whole 3D MRI input without providing tumor locations into the model. The score extracted from the 3D CNN models, namely Deep Prognostic Index or DPI, can predict the survival after 1 year correctly, both in IDH wild type and mutant cases. For model comparison, SE Resnex 50 outperformed other CNNs in external test sets. In a joint plot, DPI and time to death duration showed significant correlation. In multivariable Cox regression, DPI showed added prognostic value independent to other clinical and molecular genetic variables. The hazard ratio of IDH was 0.04, and that of TPI was 0.036, which was comparable. And C-index significantly increases after adding the DPI. So these results indicate that the imaging or the global information is independent and comparable to prognostic data compared to the IDH, which is local information. In multimodal prognostication, they developed multimodal deep learning model to predict recurrence risk in pediatric low-grade glioma. The recurrence rates are variable, strongly dependent on the extent of resection. They pre-trained segmentation model NN unit using only 400 patients and used the latent features as deep learning extracted features for another NLP concatenated with clinical variables in the last fully connected layer. The Kaplan-Meier plots demonstrate the significant stratification for each clinical feature model, MRI-only model, and combined multimodal model. You can see the gap increases as the model progresses, and risk distributions for multimodal model was more calibrated compared to image-only or clinical-only models. In patients' cases from the test set, where baseline clinical risk factors were similar, for example, resection status, but had different recurrence patterns were analyzed. For example, the first cases were both with GTR, and in patient 1, the predicted survival probability showed decrease after 23 months, which showed recurrence in 3 years. However, in patient 2, there was no recurrence in 3 years. The survival probability stays the same as the time progresses. Finally, the incorporation of imaging features improved risk prediction. The final part is about large language models. The final paper deals with monitoring patients using LLM in glioblastoma. They investigated the potential of large language models like GPT-4 to summarize complex clinical and imaging data, particularly in glioblastoma patients for longitudinal assessment. The 5 consecutive radiology reports were provided to GPT-4 for 75 glioblastoma patients, and they used LLM GPT-4 to simultaneously produce text summary as well as the R code to visualize the disease course with therapies with graphics. GPT-4-based summaries achieved overall agreement in 91% with experts, adequately representing the disease course. Also received good quality scores, and none of the summaries were rated as having negative consequences, such as omitting relevant information or adding incorrect information. To recap, deep learning improves imaging itself and reliability, diagnostic and prognostic performance, and clinical workflows indeed existing everywhere. In conclusion, deep learning is no longer novel, but now exists everywhere. Generative multimodal models are more powerful than discriminative unimodal models. However, this does not mean that everything is possible via deep learning. Thank you for your attention.
Thank you, Dr. Choi, for your talk. I think it was really quite a good overview of all the different ways in which deep learning can contribute towards the practice of radiology, all the way from, like you said, enhancing the images to assisting in diagnosis, and also actually in summarizing our reports and how that works. But can I ask one question that I'm always curious about? Out of all the things that you presented today, how many of these techniques are you actually using in clinical practice in SNUH in your department?
I think it's very good question and excellent question, because that is the the problem that we cannot solve yet because of the generalizability. Actually, we talk about that, and we say that neural networks are generalizable uh, because they have at least 1,000 cases for per class for the classification network models. But in clinical practice, that kind of large numbered data set is not usually fulfilled. So especially in the rare brain tumor glioblastoma. So, but there are some working neural network models, such as segmentation or reconstruction models, which can be learned by neural networks with relatively smaller size of data sets. So in our hospital, we use AI engine with MRI reconstruction models for clinical practice to read for real patients. So, so I think the most generalizable neural network models are two models, which is segmentation and the MRI reconstruction models.